Sexually transmitted infections, by definition, require the involvement of more than one person. Even if the urban legend of catching something from the toilet seat were true, it wouldn't negate the fact that more than one person is necessary for the spread of STDs. So if we are ever going to be able to control sexually transmitted infections, which are still a major problem in our world, we will need to find a way to effectively treat the partners of people who are infected. One way that has recently been shown to be effective in treating partners is expedited partner therapy, which is now being encouraged by the public health community. If you're interested in learning more about expedited partner therapy and the current status of sexually transmitted infections in Minnesota, please stay tuned to today's episode of A Public Health Journal.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Director and Chief Officer of Boynton Health Service, University of Minnesota. A Public Health Journal is sponsored by the Hennepin County Health Department, Boynton Health Service, the Minnesota Public Health Association, and the City of Minneapolis, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to get an update on the status of some of the major sexually transmitted infections in Minnesota. We'll also be discussing a new approach to treating the partners of people diagnosed with STDs. It's called Expedited Partner Therapy, which is treating the partners of people with STDs without needing a medical visit. This approach was recently approved by the Minnesota State Legislature. Joining me in this discussion is Peter Carr, manager of the STD and HIV section of the Minnesota Department of Health. Peter, welcome to our program.
Thank you. Glad to be here.
And I know STDs have been around for a long time, but there's lots of misperceptions about STDs and a lot of confusion about STDs. So sort of give me a definition of what is a sexually transmitted infection or sexually transmitted disease.
Like you said, it takes two people, and the definition is it's an infection that's passed through some kind of sexual contact.
All right, and so are there just a few of them, or are there lots of diseases?
There are at least 25 sexually transmitted diseases. The ones we most commonly hear about are the ones that get reported to the Minnesota Department of Health, and those are chlamydia, gonorrhea, and syphilis.
Okay, and what are some of the other ones that people may not regularly hear of?
The ones that people may not hear normally are, and in fact are quite common, are viral infections like herpes and human papillomavirus. And of course, HIV can be sexually transmitted as well.
Okay, so HIV is considered a sexually transmitted infection, but you can also get it in other ways other than just
exactly.
sexual.
It's not exclusively transmitted by sexual contact. HIV can also be transmitted from mother to child and by contaminated blood products like sharing, injecting drug use equipment, for example.
Mm-hmm. And so is like hepatitis B also in that kind of category?
Yes, hepatitis B and hepatitis C are also considered sexually transmitted infections, although they have a number of ways that they can be transmitted as well.
Mm-hmm. So what's the number one STD in Minnesota?
The number one STD in Minnesota and around the country is chlamydia. In fact, it's the most commonly reported infectious disease. In 2008, we're going to have over 13,000 cases of chlamydia reported to the state health department.
Wow.
And that may well be the tip of the iceberg, because one of the characteristics of chlamydia is that it often has no symptoms, so people may not be aware that they're infected.
Mm-hmm. So what is chlamydia?
Chlamydia is a bacterial sexually transmitted infection. It's transmitted through unprotected sexual intercourse, and it can also be transmitted via oral sex, but that's less common.
Mm-hmm. And what kind of symptoms does it cause when it causes symptoms?
When it causes symptoms, it can cause a discharge from both males and females. However, like I mentioned, especially among females, in something like 70% of the cases, there are no signs or symptoms of the infection whatsoever.
Mm-hmm. So males are more likely to have symptoms when they get it?
Yeah, males are a little bit more likely to have symptoms, and that would include discharge, and it could include burning upon urination, for example.
So other than having the symptoms, what are some of the negative side effects of having
Well, one
chlamydia?
of the bad things about chlamydia is, especially for women, there are long-term reproductive health consequences. Multiple untreated episodes of chlamydia can lead to bad things like ectopic pregnancies and infertility, and pelvic inflammatory disease.
Does it have any effect on the baby when the baby comes out?
It can affect the babies. Then the babies are routinely treated on delivery to prevent that.
And so are there, so a lot of them are not reported. So how easy is it to spread? Obviously, it must be pretty easy.
Yeah, it's easy to spread. I don't know off the top of my head. I'm not sure the exact percentage. Like if out of every 1,000 encounters, what's your chances of contracting chlamydia? But it's easy to spread.
Right. And how is it treated?
It's treated with an antibiotic, and in fact, it's easy to treat. There's a single-dose medication, azithromycin, which effectively treats chlamydia. So it's easy to treat.
All right. And so if you're going to keep it from spreading, I suspect you have to treat both the male and the female.
That's a key thing. I mean, it's one thing to treat the person who's infected, but if the partner or partners aren't treated, then the person can go out and become reinfected. And in fact, of the cases that are reported to the Minnesota Department of Health, somewhere in the neighborhood of 12% are reinfected within a year, which indicates that their partners have not been treated.
Right. And is there a preventive measure? Can people keep from getting infected? Is there something that they can do?
Sure. I mean, the one obvious one is abstinence. That's a clear-cut way to prevent sexually transmitted infections. But for people that choose to be sexually active, condoms are an effective way to prevent chlamydia if they're used appropriately and consistently.
All right, so all the time.
All the time, exactly. And especially high-risk situations are people that have multiple partners or have a new partner. Those situations are even riskier as far as acquiring chlamydia.
Right. And so we were talking about partners, how the importance of partners. So
Right.
How do you get at the partners? If a STD is reported to the local health department and the Minnesota Department of Health, what does the health department do to follow up with those reports?
Well, the answer is it depends.
Good. I love those kinds of answers.
It's not that simple. For chlamydia, we don't have the resources to follow up on all the partners, and that's one of the main issues. With over 13,000 cases reported a year, there's just simply no way that we can effectively try to contact and ensure partners are treated. We do have a group of people, disease investigation specialists, who will follow up on all newly diagnosed syphilis and HIV cases, and we'll also follow up on untreated chlamydia and gonorrhea cases to make sure that the index patient is treated. And that's why expedited partner therapy is so important, because it's another option for getting partners treated who might not otherwise be treated.
I don't want to come back to that, but you mentioned untreated chlamydia. You follow up on those. Well, tell me about that.
So what happens there if someone comes into a clinic, is diagnosed with chlamydia, and the results can take a week, several days to a week. The lab results can take several days to a week to get back to them. So if the person does not return for treatment and the clinic notifies us, that's one of the services that we provide, is to help locate those persons and make sure that they do get in for treatment.
Okay. Now I know that certainly when I was, treating STDs, we'd have somebody, was infected. We'd say, all right, you have to bring your partner in to get treated.
Right.
I suspect that's quite difficult at times.
That is difficult. I mean, it's a challenging proposition for a number of reasons. It's an awkward conversation for a lot of healthcare providers. It's an awkward conversation for a lot of patients who may not want to disclose their partners, and in some cases may not even know the names of their partners. So there are lots of issues related to getting that partner information and then doing effective follow-up.
All right, so for things like chlamydia, how about gonorrhea? Do you have outreach for gonorrhea cases too?
Again, our typical approach to our services is to try to follow up on untreated gonorrhea, but there are typically around 3,000, a little better than 3,000 gonorrhea cases reported to the health department every year. And again, we don't have the resources that we need to be able to follow up on all of those.
And this is another disease that is relatively easily treated, isn't
Absolutely.
it?
Gonorrhea can be treated readily with antibiotics.
Okay, good. Now I want to talk about expedited partner therapy, but before we get that, we need to take a little break.
Okay.
We'll be back right after this message.
Son los números que importan en tu vida.
Tu talla.
El celular de tu novia, los cumpleaños de tus hijos.
Si tienes diabetes, el número más importante de tu vida, el que debes saber sí o sí, es tu A1C.
A1C. A1C.
El A1C es el número que le dice tu doctor si tu diabetes estuvo bajo control los últimos 3 meses.
Porque si tu diabetes no está controlada, tu
corazón podría estar en riesgo.
Pregúntale a tu doctor cuál es tu A1C. Él lo sabe.
Tú debes saberlo también.
Únete a la campaña Ahora sé mi A1C.
Welcome back. We're discussing STDs and expedited partner therapy with Peter Carr from the Minnesota Department of Health. All right, Peter, let's talk about expedited partner therapy. It's a new phrase, a new term that I don't think a lot of people know about, and it's a relatively new concept from what I understand. So give us a little background on expedited partner therapy for sexually transmitted infections.
Sure. What expedited partner therapy is treating the partners of people with an STD without a medical exam. And the reason that's important is managing the partners of people with sexually transmitted infections is critical, both from a personal health perspective and from a public health perspective. So partner management is really a cornerstone of STD prevention and control. There are a variety of ways to do that. The best way, and still the first choice, is to get the partner in to see a healthcare provider. And in many cases, however, that's just for a wide range of reasons not possible. So that's why it's an exciting opportunity for Minnesota to have expedited partner therapy as an option for treating partners.
All right, so how does it work? So let's say a woman comes in and she's got chlamydia. So the doc or the nurse practitioner or the PA or who's ever treating that person, how do you go about it?
So first of all, you have to determine if the person is a good candidate for expedited partner therapy. So you make the assessment that the partner is not likely to come in otherwise. So you got someone in there who looks like...
So you'd still, if possible, the ideal would be to get the other partner in.
Exactly. But a lot of times that's just not going to happen. Mm-hmm. So the way it would work is, once that assessment is made, there are two ways that can be done. And the most common one is to give the patient a dose of medication to bring home to give to their partner. And that's always accompanied by an information packet that includes information on what the treatment is, how to do it, what to watch for in terms of side effects, and also some preventive messages. Mm-hmm. Second way to do it is to provide a prescription for the partner. So the patient walks out the door with a prescription that they can take to their pharmacy and get filled. Mm-hmm.
So what if they have more than one partner? Well, what if they have 6 partners?
Well, that's always possible. Typically, the recommendations are to supply no more than 3 or 4 doses of medication or 3 or 4 prescriptions.
Okay. So when I go to the pharmacy with a prescription, my name is on the prescription. How does a doc write a prescription without having a name on there? Is that a problem?
It had been until last year when the Minnesota legislature, revised the Minnesota pharmacy practice laws to permit writing a prescription without the patient's name on it. So that's an option. The name could be filled in later. How this is going to work, we still have a lot to learn about, but it's going to take some creativity.
Right. So what year did the legislature pass that?
The legislature passed it in the 2008 legislative session, and we've been actively working to implement and help promote expedited partner therapy since late in 2008. Mm-hmm.
And how has it been accepted by the medical community?
I think we're still learning about that. We just embarked on an initial pilot evaluation of that, in fact. But based on the response that we had to a seminar this January, in which about 75 healthcare providers attended, we think it's going to be readily embraced. Mm-hmm. Not by everyone, of course. There are issues with it. Not everybody thinks it's a good idea. And I think over time we'll see more and more providers embracing this as a...
Well, I know the Minnesota Medical Association was supportive of expedited
Exactly.
therapy.
The Preventive Health Committee, in which you were the chair at the time, was very helpful in adopting a resolution that endorsed expedited partner therapy, as does the American Medical Association, and it's also a recommendation from the Centers for Disease Control.
So what are some of the reasons people aren't really supportive of it?
There's some potential barriers. One of them is legal. Providers may wonder, can I get sued? Mm-hmm. And the answer is, of course, you can always be sued. But there's no indication that is actually an issue. And in fact, as expedited therapy becomes accepted as a standard of care and is the way that the best practice for managing, one of the best practices for managing partners, that may not be an issue. Mm-hmm. And in fact, ironically, once that happens, there may well be the potential for not providing expedited partner therapy for legal ramifications.
Mm-hmm. So what about allergies? A lot of people can't take certain medications, so you don't know the allergy status of somebody you've never met and you can't even ask them. How do you get around that?
That's another good question. Adverse reactions to the medications. The answer to that is the drugs that are commonly used to treat gonorrhea and chlamydia, which are the two diseases that are appropriate for expedited partner therapy, they're third-generation antibiotics, and there is minimal to almost no potential for serious adverse drug reaction to that. And in fact, in California and Washington State, where expedited partner therapy has been up and going for a number of years, they initially had a reporting system for providers to call in and report adverse events, and they haven't had any. So the experience so far in other states is that it's truly not an issue.
What role does the pharmacist play in this? I mean, in terms of educating and checking on allergies and things like that?
Well, the pharmacist's role would be to provide information like they do for any drug. I know when I get a prescription, my pharmacist asks me if I've ever had this particular medication before, and they provide me with information about the drug and potential side effects. So it'd really be no different.
Right. So when I go to the doc and they write a prescription, it's covered by my insurance.
Right.
How does this get paid for?
Cost is a big issue and is one of the barriers that we're exploring some options. And there are a variety of options. One of the options, if the clinic has the resources, is to just provide the drugs directly to the patient. That's actually the patient. That's the most. Handing the patient a dose of medication is the most effective way to get this done. So if the clinic has resources to do that, that's an option.
Yeah, but I can't imagine insurance companies would be interested in paying for the medication.
Medicaid, third-party payers, if they're not a member of that, they don't have if they're not a member of the group or don't have a policy, they're not eager to pay for additional drugs. So,
yeah, but what about Medicaid or Medicare?
Medicaid does not provide for that payment as well.
Okay.
So I think over time, as this becomes more of a standard and accepted practice, people will begin to get it, and we're hopeful that some of those payment issues will begin to work out. Unfortunately, the drugs used to treat these two infections are relatively inexpensive.
All right, now you mentioned that the CDC was supportive of this. I suspect there's been some research that this is an effective way to get at sexually transmitted infections?
Exactly. CDC doesn't support anything unless it's an evidence-based approach. So there were several randomized controlled trials, which is the gold standard for proving effectiveness, that shows that EPT is effective in reducing repeat infections. So based on that's the real basis for the CDC's guidelines.
Now, you mentioned other states. How many states are doing this, and are there laws in these states to protect the providers?
I think there are probably 5 or 6 states that are actively engaged in EPT. So Minnesota is actually at the forefront of this. And there are no specific laws to protect providers. There are laws that may provide cover. So for example, our pharmacy practice law says it's okay to do this, and there's nothing else in statute that makes it illegal. And our Board of Medical Practice wouldn't pursue any kind of an action against a physician or provider that used EPT.
Now, why not use expedited partner therapy for all in STDs?
Well, that's a good question.
Chlamydia and gonorrhea.
Yeah, another one that's on the rise in Minnesota is syphilis. And the issue with syphilis is that, number one, it's hard to diagnose. And secondly, it requires an injectable drug. So for syphilis, it's probably never going to be an option. For other common infections like trichomoniasis, it hasn't been proven to be effective. That may come as more studies are done, but right now the recommendations are based on diseases where it's been shown to be effective.
All right. Well, you mentioned syphilis, and I want to talk about that in the last part of our program, but we need to take another break.
All right.
We'll be back right after this message.
Hey, guys. Ooh, I've been looking for that. Has legal seen this?
Yeah. Cheryl, what happened to your,
Oh, yeah, I know. If it gets any worse, I'll have it checked out.
Worse? How could it get worse?
Yeah, maybe we should call somebody?
I'm fine.
You wouldn't ignore this, so why ignore the signs of a stroke? At the first warning signs, call 911 immediately, because time lost is brain lost.
We're discussing sexually transmitted infections and expedited partner therapy in Minnesota with Peter Carr from the Minnesota Department of Health. Peter, recently on the news we saw that cases of syphilis in Minnesota have increased dramatically over the last 12 to 18 months. What's going on with this? Because I thought syphilis had been at a pretty low level and had been pretty good, well under control. What's going on?
Yeah, what it had been, in fact. Syphilis numbers had declined. There was a slight bump in the late 90s, but then dropped down to fairly low levels. Then starting in 2002, we began to see an increase, especially among men. And that level of increase really accelerated in 2008, where we saw a 40% increase in early syphilis cases, which means syphilis infections of a year or less in duration.
So what has changed in that time?
So what's been going on basically is that there has been an increase among gay men. That's what's driving the increases we've seen since 2002, and in fact is the strongest element of what's going on in 2008 as well. So it's syphilis among men who have sex with men.
Now, so what has changed? I mean, we had argued and proselytized about safer sex and using condoms, and we really had been fairly successful. Has that changed? Is there less education? Is there less knowledge about what's going on?
The level of education has continued, so I'm not sure that's the issue. There are probably a number of things at play, and two things that come to mind are that for older gay men, there have been, since the advent of HIV 25 years ago or so, there's been a constant barrage of prevention messages. And there is a thing that people refer to as prevention burnout. They're tired of the same old messages, and it's just getting old. For younger men, one of the issues is that HIV doesn't have the dramatic impact that it did 25 years ago when HIV was essentially a death sentence. Just about a lot of people died. Gay men saw a lot of their friends and partners dying. That's not happening anymore as a result of the success of the treatments for HIV. So
people don't see it as such a big deal anymore.
Yeah, exactly. It's not having the impact. And for syphilis, another possibility could be like, yeah, so what? I can treat it. It's no big deal. I just go in and get a shot and I'm good to go. So sense of complacency.
Yeah. Now, I suspect it's among men having sex with men and HIV because of the immune system. So if your immune system is down, you're more likely to contract syphilis?
Yeah. In fact, people with a sexually transmitted disease like syphilis are something like 3 times more likely to both transmit and acquire HIV. So it provides a portal. And one of the scary things about the increase in syphilis, and it's been consistent over the last 4 or 5 years, is that about 40% of the gay men with newly acquired syphilis infections have an existing HIV infection.
So they're combined pretty tightly.
Yeah.
And now there's a whole new way of meeting people. Is anonymous sex still a major problem, and internet kind of pickups and things like that?
It is. The internet has made it way easy to connect with people in a rapid fashion. There are a number of sites that are designed just to do that. Manhunt.com, for example, is one of them, or even MySpace. But what it does is it makes it a lot easier to hook up with guys, and anonymous sex goes along with that.
So with this major increase, what's the health department doing to try to turn the direction around?
Yeah, a couple of things. One of the key things for syphilis is to get tested. So the recommendations are that gay men should be tested once a year for syphilis. Symptoms or not. It's just a preventive precautionary measure. So testing is important. So we've been trying to get out the word to the community that syphilis is here, it's increasing, and it's important to be aware of it and get tested. Likewise with healthcare providers. We've been attempting to educate healthcare providers on the need to be thinking about syphilis, to be thinking about screening their patients who do have sex with men for syphilis on an annual basis.
Well, it used to be everybody got an RPR or a test for syphilis. Every admission to the hospital, every application, you had to get a test. That went away.
It did. There's really no rationale for general screening in the general population for syphilis.
Right. No, but you talk about screening. I suspect screening and testing is important for all of the sexually transmitted infections.
Absolutely. It's critical for chlamydia and gonorrhea as well, and in particular chlamydia, where, as we were talking about, a majority of people with a chlamydial infection have no symptoms. So the recommendations that are in place are for women, and they are simply that any sexually active woman under the age of 25 should be screened once a year, regardless of any other history or change in partners or whatever. And then as a follow-up, someone with a sexually transmitted infection is at risk for reacquiring one, so they should be rescreened in 3 to 6 months as well. And what screening is, just to clarify, that's testing, doing a lab test in the absence of any symptoms. So it's not a diagnostic test. It's a test to see if you have a hidden infection, essentially.
So if somebody comes in for a pap test,
Yeah.
they also do a screen for chlamydia and other sexually transmitted infections?
Yeah, especially chlamydia. If a woman's coming in and is getting a pap test, that's an indication that she should be screened for chlamydia as well.
How about guys? Do they get screened on a regular basis?
There aren't any formal recommendations for that, but it's pretty clear that it's a shared experience. So women are getting it from their male partners, so men should be screened as well. One of the issues for men is they're way less likely to go see a healthcare provider compared to women, who oftentimes will go in for an annual exam.
Right.
Guys, especially young guys, they don't go to the doctor unless they really need to. So.
Yeah. Well, Peter, this went by way too fast,
Yeah.
and we have to stop now. But I'm going to put on the website for the Expedited Partner Therapy and the telephone number, so if people want more information, they can get it from the State Health Department, I suspect.
Absolutely.
Great.
Yeah.
Thanks for being with us.
Thank you.
I'll be back with a closing message right after this message.
AIDS has created over 14 million orphans worldwide. That's the equivalent of every child under 5 in America, with no one to watch over them. Please, won't you help?
In the field of public health, there is an ongoing discussion about who is ultimately responsible for health. Is it an individual responsibility, or is it the responsibility of government? The arguments have arisen when things like laws are proposed to mandate the use of motorcycle helmets or ban smoking in cars when children are present. In reality, health is both an individual and a societal responsibility. That's because no individual is completely independent of the society in which he or she lives, and individuals make choices in the context of that environment. Ideally, society, through government, should develop an environment that doesn't take away individual choice, but makes it easier for people to choose activities that enhance health. It should develop laws that maintain the delicate balance between individual freedom and choice and public good. Expedited partner therapy is a good example of a public health approach that maintains this balance. The law that permits expedited partner therapy makes it easier for people to make the right choices for their health, the health of their partners, and ultimately the health of our community. Certainly, there are some risks in leaving some of these decisions in the hands of individuals and not being more aggressive in forcing people into treatment. But the benefits in terms of cost and long-term quality of care far outweigh these risks. Expedited partner therapy is a pragmatic approach that is based on sound public health principles, and it works. So tell your partner about it. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.